Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of periorbital and orbital cellulitis for general pediatricians. These two conditions can look similar at first glance, but one is a benign skin infection, and the other is a sight-threatening and even life-threatening emergency. Across the next cases, we will work through the anatomy of the orbital septum, the role of paranasal sinuses, distinguishing clinical features, microbiology, imaging indications, antibiotic selection, complications, special considerations in infants, and expected recovery timelines. Let us begin. Case 1. A 3-year-old boy presents with sudden onset of left eyelid swelling and redness. On examination, there is unilateral left eyelid erythema and edema. Visual acuity is intact, and eye movements are full and painless. Temperature is 37.8 degrees Celsius. Which feature on this examination is the most reassuring sign that this is preseptal rather than postseptal cellulitis? Option A, unilateral eyelid erythema. Option B, preserved visual acuity and full, painless eye movements. Option C, fever and elevated temperature. Option D, sudden onset of symptoms. The correct answer is option B, preserved visual acuity and full, painless eye movements. This is the hallmark distinction at the bedside. Periorbital cellulitis, also called preseptal cellulitis, affects only the tissues anterior to the orbital septum, so the globe, the extraocular muscles, and the optic nerve are not involved. Orbital cellulitis, by contrast, involves structures behind the septum and presents with proptosis, restricted or painful eye movements, and decreased vision. Those features are red flags that demand urgent imaging, intravenous antibiotics, and specialist consultation. Eyelid erythema, fever, and sudden onset can occur in both. Case 2. A 4-year-old girl is brought to the clinic with left-sided eyelid swelling that began 2 days ago. Her mother reports she had a runny nose and cough for the past week. On examination, the child has a mild fever of 38.2 degrees Celsius, unilateral eyelid erythema, and mild edema. Visual acuity and eye movements are normal. You suspect the infection may have spread from her sinuses. Which anatomical structure is the most common source of infection in periorbital cellulitis when it spreads from the paranasal sinuses? Option A, frontal sinus. Option B, ethmoid sinus. Option C, maxillary sinus. Option D, sphenoid sinus. The correct answer is option B, the ethmoid sinus. The ethmoid air cells sit immediately medial to the orbit, separated only by a paper-thin bony plate called the lamina papyracea. This thin, porous bone is easily breached by infection, allowing rapid contiguous spread of bacteria from the sinus into the orbital and periorbital tissues. In addition, the facial venous system around the orbit is valveless, which means pathogens can also travel by retrograde venous flow, raising the risk of posterior extension and cavernous sinus thrombosis. This is why an upper respiratory infection or sinusitis in a young child can quickly progress to eyelid or orbital cellulitis. Case 3. A 2-year-old boy presents with acute right eyelid swelling and erythema. On examination, you note unilateral eyelid swelling and mild conjunctival swelling, also called chemosis. The child is able to move his eyes in all directions without pain, and visual acuity appears intact. Temperature is 38.5 degrees Celsius. Which of the following findings would most concern you for orbital cellulitis rather than periorbital cellulitis? Option A, chemosis and fever. Option B, pain with eye movements and restricted extraocular motility. Option C, unilateral eyelid erythema and edema. Option D, mild conjunctival swelling alone. The correct answer is option B, pain with eye movements and restricted extraocular motility. These two findings are the cardinal red flags for orbital cellulitis because they reflect inflammation of the extraocular muscles and orbital fat behind the septum. Other warning signs include proptosis, or forward bulging of the eye, and decreased visual acuity. Mild chemosis and fever can occur in severe periorbital cellulitis as well, so on their own they do not confirm orbital involvement. When pain with eye movement, restricted motility, proptosis, or vision change appear, the patient needs urgent contrast-enhanced imaging, intravenous antibiotics, and ophthalmology or ear, nose, and throat consultation. Case 4. A 5-year-old girl with periorbital cellulitis is started on empiric antibiotics. Blood culture is obtained. The child has no known drug allergies and is otherwise healthy with age-appropriate vaccinations, including the Haemophilus influenza type B vaccine. Which organism is most commonly isolated from pediatric periorbital cellulitis in a well-vaccinated child? Option A, Staphylococcus aureus. Option B, Haemophilus influenza type B. Option C, Streptococcus pneumoniae. Option D, Neisseria meningitis. The correct answer is option A, Staphylococcus aureus. In the modern, well-vaccinated pediatric population, Staphylococcus aureus is the most common cause of periorbital cellulitis, often after minor trauma, an insect bite, or a small skin breach. Streptococcus pneumoniae and Streptococcus pyogenes are also important pathogens, so empiric therapy must reliably cover gram-positive cocci. Haemophilus influenzae type B was historically a major cause, particularly in children younger than 5 years, but it is now rare thanks to widespread Hib vaccination. Unvaccinated or incompletely vaccinated children remain at risk. In areas with significant methicillin-resistant Staphylococcus aureus, empiric coverage may need to be expanded. Case 5. A 4-year-old boy presents with unilateral eyelid swelling, erythema, and mild fever. On examination, visual acuity is normal and eye movements are full and painless. You are considering whether imaging is necessary. In a child with clinical findings consistent with periorbital cellulitis and normal eye movements and vision, when is imaging most indicated? Option A, routinely for all cases to confirm diagnosis. Option B, only if the diagnosis is unclear or red flags for orbital cellulitis are present. Option C, only if symptoms do not improve within 24 to 48 hours despite antibiotics. Option D, never, as clinical diagnosis is sufficient. The correct answer is option C, only if symptoms do not improve within 24 to 48 hours despite antibiotics. However, the broader principle is that imaging is reserved for specific indications and is not routinely required in mild, classic periorbital cellulitis that responds promptly to therapy. Contrast-enhanced computed tomography of the orbits and sinuses is indicated when there are red flags, such as proptosis, limited or painful eye movements, vision changes, when the diagnosis is uncertain, when the child fails to improve within 24 to 48 hours of appropriate antibiotics, or when complications are suspected. Computed tomography is essential to confirm orbital cellulitis, identify subperiosteal or orbital abscesses, evaluate sinus involvement, and plan surgical drainage if needed. Case 6. A 3-year-old girl presents with left eyelid swelling and erythema. She is afebrile, appears well, and has normal visual acuity and eye movements. On examination, the swelling is mild to moderate. You are deciding on the appropriate management setting. Based on the clinical presentation, this child most likely has which severity classification of periorbital cellulitis? Option A, severe periorbital cellulitis requiring hospitalization. Option B, mild periorbital cellulitis suitable for outpatient management with oral antibiotics. Option C, orbital cellulitis requiring admission and intravenous antibiotics. Option D, periorbital cellulitis requiring imaging before treatment decisions. The correct answer is option B, mild periorbital cellulitis, suitable for outpatient management with oral antibiotics. A well-appearing, afebrile child with normal vision, normal eye movements, and only mild eyelid swelling can usually be managed at home with oral antibiotics, provided that reliable caregiver follow-up and a clear safety net plan are in place. Moderate cases with more extensive swelling but no orbital involvement may need a brief admission or a hospital-in-the-home pathway, often starting with intravenous therapy and stepping down to oral. Severe periorbital cellulitis and any case of orbital cellulitis require immediate admission, intravenous antibiotics, urgent imaging, and specialist consultation. Case 7. A 4-year-old boy with mild periorbital cellulitis is being treated as an outpatient. He has no drug allergies and is otherwise healthy. You are selecting oral antibiotics. Which oral antibiotic is most appropriate for outpatient treatment of mild periorbital cellulitis in a child? Option A, amoxicillin alone. Option B, cephalexin or cefuroxime. Option C, penicillin V. Option D, erythromycin. The correct answer is option B, cephalexin or cefuroxime. First-line oral antibiotics for mild periorbital cellulitis include cephalexin at 20 mg per kilogram per dose 3 times daily with a maximum of 500 mg per dose, or cefuroxime. For cefuroxime in children aged 3 months to 12 years, the dose is 20 to 30 mg per kilogram per dose twice daily with a maximum of 500 mg per dose. In children over 12 years, the dose is 250 to 500 mg per dose twice daily. These agents reliably cover Staphylococcus aureus and Streptococcus species. Amoxicillin alone is inadequate because it does not cover beta-lactamase-producing Staphylococcus aureus. A full 7 to 10-day course is recommended to prevent recurrence. Case 8. A 5-year-old girl was started on oral antibiotics for periorbital cellulitis 2 days ago. Her mother calls reporting that the swelling has worsened, the child is complaining of eye pain with movement, and she has noticed the eye appears to be bulging forward slightly. These new findings suggest progression to orbital cellulitis. Which of the following is not a typical complication of untreated orbital cellulitis? Option A, cavernous sinus thrombosis and intracranial extension. Option B, subperiosteal